I think Natasha was the first fellow, Rohit, to get the PhD from Narayan Netralaya team. And since Natasha's time, I mean, we have been knowing Narayan Netralaya because she was very active globally.
A very powerful celestial force that has been guiding me, my mentor, Dr. Rohit Shetty. It's a statutory warning. In the next 10 minutes, if we are impressed and we take something back home that we can implement today itself, that's because of the way we are trained. But if I mess up, that's because I was a bad student. All right, so we're going to just absolute basics, and then we'll slowly graduate to little advancements. Why are we talking of Schwind platform? What is so special about Schwind platform is, you see, everybody's got a different fingerprint. Every patient is different. So that demands customized treatments for our patients. And for me personally, having worked on all different platforms, I personally love this machine. And that's what we're going to discuss. Why? Because every fingerprint has got a treatment module available for it. And step by step, let's not just get busy with these slides. Step by step, we're going to see how, if I have to start doing laser on Schwind machine, how do I do it? Now, if I have to make a recipe, I need all the ingredients in place, right? What are those ingredients? These are those ingredients. For a refractive surgeon, most of these ingredients are absolutely necessary. Some of them can be avoided. And that's what we're going to discuss. If I had to summarize all, if I had to put all of that in one table, this is the chart. All of it comes in this step. So from my optometrist to the refractive surgeon has to follow this chart. So it's like a pilot's checklist. All of these have to be in place, then we go ahead and perform the refractive surgery. Let's come to the most important aspect, that is the holy grail, that is our corneal topography, because these are the machines that get exported. The first and most important aspect, as everybody has discussed, is the quality of scan or the quality of acquisition. Now, if you see here, although the quality of scan, the coverage is good, the centration is good, but if you see, there is superior-inferior asymmetry. Now, I am little wary, should I go ahead doing femto LASIK for this patient or should I do a surface ablation? And that's where it's very, very important. Most of the time, the technicians take the scans. It's important that we go and look at those Scheimpflug images. You see the centration, the red cross has to coincide with the Purkinje image, the first Purkinje image. And that's where the centered scans are. And those are the scans that should get exported. How do you actually check it? Go on statistics of acquisition. I'm talking only on Cirrus. It will tell you how centered. So you see the keratoscopic center here. It has to coincide with the central cross. That means the scan is very well centered. And that's the scan that should get exported. It's very simple. You see those star marks up. Just highlight the star mark. That scan becomes the center of attraction for all your treatment plans. Right, coming to the most important aspect, we talk of corneal topography is very important. Do we need an abrometer as well? If you have a corneal topographer, most corneal topographers will give you an abrometry. They may derive it from ray tracing or they may derive it from just structure itself and they simulate the abrometry, but they do it. So why is abrometry so important? Because it will help us decide what kind of treatment plan should I do. Obviously, if the aberrations are much higher, you would want to correct it because the quality of vision improves. As Dr. Wavikar said, there are patients who have 6/9 vision with glasses. We can achieve 6/6 with them. Now, if the subjective acceptance is correct, why is it that they are not able to achieve that 6/6 vision, right? So the quality of vision depends on our aberrations. And that is what gives us. So most importantly, at least in Cirrus, it will also give you the ray tracing refraction. And you can compare it to your subjective acceptance and then decide. If the aberrations, higher order aberrations are less, please go ahead with aberration-free treatment because we are born. These are our innate aberrations. As Sir says, these are our commensal aberrations. We are born with it. If you suddenly shift it, the patient may not look happy. The abrometer will look 0, 0, perfect abrometry, but the patient will not be happy. So until unless the patient is not symptomatic, do not touch it, do no harm. And of course, depending on the subjective acceptance, you can also see how different is the abrometric or the ray tracing refraction. If there is a significant difference in the subjective acceptance and the abrometry or the ray tracing refraction, that means the aberration, some of the cylinder, for instance, is actually coming from the coma. And these are the patients who need corneal wavefront treatment or wavefront guided treatments. And this is what we're going to be discussing. Now, step 1, this is a treatment platform. It will give us the aberration-free ocular wavefront and the corneal wavefront treatment. And you can decide what kind of procedure you want to do depending on the topography. Coming to the entire busy slide, I just want to highlight the simplest stepwise manner of how we go ahead. As discussed earlier, I'm showing you one example of each. If it's an aberration-free treatment, that means the higher order aberrations are not too much. It's a very, very simple thing that we need to do. So you just go on the Schwind Ameris treatment platform. I'm just going to speed up the video. So you go ahead and select the aberration-free treatment. You don't need to do anything else, just import the corneal data from wherever you're doing. Why is corneal data important? Is because it will take the pupil center and the iris pattern as well. So if there is some amount of cyclotorsion, irrespective if there is astigmatism or not, the scan is always centered. So even if the patient is moving while the treatment is happening, the Schwind Ameris platforms has got 7-dimensional tracking. So even if the eye movement is not happening in X, Y, Z axis, it also corrects any direction. So the entire laser profile moves along with the micro movements of the patient, which is why the precision of this treatment is much, much superior. So yeah, you essentially go ahead and put in the refraction after importing the corneal data. Decide what kind of treatment you want to do. The advantage here is, you see there is an option of post CXL. Why is this important? Is because this machine corroborates that the patient's cornea is going to be slightly stiffer. So the ablation profile changes. If it is a relift, it will also change the ablation profile. So basically it factors in that the cornea has already undergone some amount of insult and it has to compensate for that. And the status of hydration is the age of the patient. All these factors are so important when you're planning a Schwind platform. So you wanted to say something?
The one thing is very interesting concept you brought in, which is very useful when you use Schwind, is never assume the age of the patient. Or if you find that it is not frivolous enough to ask some lady her age and write whatever you feel like, machine ablation based on age. It assumes that every decade your cornea becomes stiffer by 10 to 12%. So if you put somebody's age as 50 by chance and the patient is 25, you will end up in overcorrection that patient because it has assumed to give 20% more laser spots on this patient. So I don't think any machine takes into the account of aging as much as what Schwind would do. So do not use a wrong age. I've had one patient in my career where somebody by mistake had written 52. The patient was 28. I thought it doesn't matter, but she had a plus 0.75 overcorrection, and that was that's when I realized the importance of age.
Thank you, sir, for highlighting that. So coming to something, I realized that a lot of individuals here are doing trans-PRK or surface ablation, and this is what the next part is. Trans-PRK had actually, surface ablation had gone out of vogue when LASIK came in, yeah, and it came back. It came back because of this particular word, trans-PRK. And why is it so important? We're going to touch upon absolute basics of it first. Every indication, so every contraindication of LASIK and lenticule extraction is an indication for surface ablation. So why did it go out of vogue? Primarily because of these two reasons, and we are still discussing about it even today. Yeah, so it was haze and pain. Now there was a beautiful, beautiful paper that was published by a preferred practice pattern that was published by Sir and group. It is a very, very simple factor that can avoid haze and pain in most of the patients. It's a beautiful chart. It's open access. Anybody can download it. We'll share the link as well. So basically you can customize and avoid these factors. Factors which were non-modifiable before suddenly become modifiable. So you can titrate these factors. Which are the machines that do trans-PRK? One is Wavelight and one is Schwind Ameris. One is called Streamlight and one is called SmartSurf. Why I like trans-PRK is because it's absolutely a no-touch technique. Why? Because it combines the PTK profile and the actual stromal ablation into one. So it superimposes both of them. So even if the first ablation, which is correcting the irregularity, is finally happening on the epithelium, but the rest of the correction is happening on the stroma. So the total correction, people say that, oh, you know what, if the epithelium is irregular, then PRK doesn't make sense because you are correcting a corneal wavefront, but the surface is going to become regular after the surgery, right? But because it's a combined procedure, combined ablation, the treatment is very, very robust. Most importantly, the advantage of trans-PRK is that because it's a defined zone. In PRK, if I have to do a surgery, I have to remove the epithelium of 9 mm. In trans-PRK, if the optical zone is 6 mm, the transition zone is 2 mm, it will only remove about 7.5 mm. So the healing is much faster, the haze is much lesser. And of course, as mentioned earlier, coming to the absolute basics, in the entire workup sheet, if you noticed, didn't give you time, but there was no epithelial mapping mentioned. In trans-PRK, in Schwind, epithelial mapping is very, very important because it gives you the luxury of putting the epithelial thickness. So you see this pattern here. You can, if a patient has got an epithelial thickness of say 70, you know that you're truly removing the epithelium. Now, advantage of MS39 is that it automatically imports it. You don't have to manually enter it. Right, this is just a simple procedure. After a SSC check, which is static cyclotorsion compensation check, you see that the patient is actually very, very uncooperative. So after the centration is done, what I recommend is you see the Purkinje image, the red Purkinje image, that's the visual axis of the patient. So the second Purkinje image has to coincide with the first Purkinje image when you're centering the scan. Even if you don't do it, after the SSC, the ablation pattern is going to be on visual axis unless you do a pupil offset and do it on a vertex, on corneal vertex.
This is a very important thing what she's doing. The reason is, let's assume you're treating a minus 0.5 and when you're treating a minus 0.5 or 0.75, what she's trying to do is she's trying to remove excessive fluid. The reason this is important is every other machine, what they do is, now what is happening is, it is correcting the power. This is the opposite of what other machine does. That means if it's a minus 0.5, the machine will first correct the power and then remove the epithelium. It's just the volume basically, whether you correct the power. But why is it important? What she did is, if it is fluid there, the first one hits the laser, the machine, if it's fluid, it will take the fluid out. So one of the major cause of undercorrection is people put, like in the beginning, I saw somebody putting saline. That's why you have to be very mindful about PRKs. When you're putting saline, there is water, and water has thickness ranging between 10 to 20 microns. So imagine if one diopter of first ablation goes only on taking that water out. And then it starts. By the time the machine actually starts ablating, there is nothing to ablate, it's just the epithelium which is gone. So removing the fluid is probably the #1 important tip in managing the PRK.
Yeah. Thank you, sir, for highlighting that. In addition to that, if you see this patient had a very strong bells. So whenever you see this now, the ablation stops. Whenever beyond a particular zone, if the patient moves, the ablation automatically stops. And the moment the patient comes back into the center, focusing on the visual axis, the ablation starts again. And that's how we know that, and the ablation starts exactly where it stopped. So we know the precision of this treatment is very, very good. I want to end this by highlighting just few important aspects of using this technology of trans-PRK, and what makes Schwind different than other trans-PRKs is this. Now you see, these are two cases that I want to discuss. One is a post-HSV scar. This patient had undergone refractive surgery, developed HSV. After 12 years, she said, I still don't want to wear glasses, I'm tired of wearing them. I was very wary of doing surface ablation on post-HSV, but she had no active episode. And she was she was put on antivirals for a very long time. I'm going to be discussing this case first. Now if you see, the vision, uncorrected vision is 618. This is a subjective acceptance. Toporefraction is very different. I have sufficient pachy. Now, if I do on ORK cam, if I do a topo guided ablation without correcting the power, that means zero refraction, you see the amount of ablation is 77 microns just to make the topography regular. Now in this case, without, you see that. So essentially what I did was, I did not correct any refraction, although the subjective acceptance was showing me significant amount of sphere and cylinder. Now you see the ablation profile. This is pre-topography and this is the ablation profile. It absolutely sits like a ball and socket joint. So it corrects wherever there is flattening, and obviously the vice versa. Now with Foresight, which is the newer software, you can actually predict what the post-operative topography is going to look like. So you can decide if you want to do an aberration-free treatment or a corneal wavefront or an ocular wavefront. Essentially, this patient underwent zero refraction, has got 6/6 vision, has got no relapse, no scar. Obviously, we had used mitomycin for this patient and a very long dose of steroids, antivirals. Coming to the speciality of this treatment is, now if you see, if I do a topo guided ablation for this particular topography, which is keratoconic, I would end up ablating about 55 to 60 microns with zero refraction. Now, we know that keratoconic cornea is already weak. I would be very wary of removing another 50 to 60 microns. So what is the solution for this? And this is what was proposed by a group at Narayan Nethralaya. It's called TREC. So essentially, you know that there is this very specifically that area which is steep. You want only that area to be flattened. So what TREC does is, you basically go to a tangential anterior map. We can discuss the planning in person if anybody is interested. Essentially, you find out the center of this, and with just 10 to 20 microns of ablation, you get what looks like. So you see the topography, I'll show you the pre-op topography. This is the pre-op topography, this is the ablation. So it will actually decenter your ablation to wherever you want it. And it will be localized only in that area. You can change the shapes of this. You want it round, you want it elliptical, you want only a ring in the periphery. Any shape you want can be done with this platform. So if you see, it superimposes exactly in the area of steepening. And with just 10 to 20 microns of this, you see a flattening of almost 3 to 4 diopters in some cases. I was very optimistic and I tried this in one patient, and I have got a flattening of almost 9 diopters with 15 microns of stromal ablation, very, very localized only in the area of the cone. Obviously, this was followed by subsequent cross-linking. What I essentially want to end is that we always are thinking, oh no, it's a keratoconic cornea, it's a very irregular cornea. There are no bad topographies. We just need to do a little bit of contouring, and it is very, very possible to make bad corneas look good. We just need to know how to manage it. Thank you very much.
So Natasha, after your talk, I am not being a refractive surgeon. I feel there's only one Ramban if you want to buy a refractive machine, and we should go for Schwind Damaris because it does everything. Thank you.
Thank you.
The only thing is like cell phones. it can do everything, but it's about how intelligent are you to make use of everything. So there are people who have the best cell phones who don't have a single feature of it. I think wonderful presentation. I think big
Thank you,
round
sir.
of.
Thank you.
Dr. Wavikar has a question.
Yes, sir.
Hello.
For relift. So actually, when you do a relift, depending on what you want to do you want to do just an enhancement, or you would want to do a zone enlargement? It depends on that also. If it's a zone enlargement, obviously the ablation is much higher.
It gives a less spots which you don't know, but if you go to the heart of the machine, because it's weaker, the cornea is weaker, it assumes that it cannot give you the same amount of spots for a particular ablation. So it plays around with the spots. And second thing, it does play a little bit. It assumes that it will change the epithelial remodeling differently. So it may give us spots which is more aspheric in nature. That means it will not give too many spots in the center. It will give more spots in the periphery.
So also the Schwind has got an advantage. It's called the AFLA, which is basically, it's got fluence changes. So 80% of the fluence that goes is high fluence. The 20% of fluence is low fluence, which basically regularizes the cornea. In relift, they do that 20% of low fluence is actually increased, so that the cornea becomes even more regular.
Second question, you said post CXL. So how frequently you are doing post CXL EPR?
I haven't done, in all honesty, sir, I haven't done any. I have done trek in one patient who had undergone CXL. But from what I understand is that it calculates. So I'd asked this from the engineers. It does calculate the way the ablation profile is, because that cornea is weaker below and stronger above. So depending on that, the ablation profile, and it's supposed to be proprietary, so that was not disclosed, but they said the ablation profile is definitely different if you just tick post CXL, and it undercorrects slightly. Of that one patient? Yeah. Yes, I did, but that was after, so first CXL had happened about 6 years back, had progression, but had still very good pachy. So I did about 10 microns of central this thing and did a CXL again. But this time I did a 9 milliwatt one. First he had undergone a Dresden protocol.
So the take home, like, is the scar for small scars, you can go whether it is HSV or anything?
Can you, I'm sorry, I didn't get that, ma'am.
For scars. You
Would I
done
want
for
to
HSV scar also. I thought it was a contraindication for any
It is.
corneal procedure, but
It is
yeah.
antivirals and mitomycin, and I have been following up this patient almost for 5 years now. There is no haze, there is no reactivation. So she was put on antivirals for almost 2 years, and she was
Before surgery?
Sorry,
Before
just two weeks before surgery, we had already started our antivirals.
Okay, and continued for 2
and
years.
continued for 2 years.
Okay.
Anything like a PK patient.
Okay. So, your opinion, like,
Yes.
for all small scars, like so many nebulous scars are there, you can just go ahead with this?
That's what she said. It's a one machine which fits everything. Aarti?
Yes.
Thank you.
Thank you.